Everyone knows about Dr. Narendra Malhotra. So Dr. Narendra Malhotra, sir, is amongst us. We are very honored. The past president of FOXY, the past president of ISAR, all possible organizations sir has headed. And my fondest memories of sir are related to ultrasound. So he is one gynecologist who has been thoroughly associated with ultrasound and teaching us. I remember I went to Chandigarh as a student to listen to ISAR and PGI. And that time sir was teaching us interventional procedures. His CV is testimony to the fact of the amount of work the Malhotra family has done in India to take academics and clinical work forward, not only in ultrasound but in all sorts of clinical departments of OBGYN as well as in fertility. Dr. Narendra Malhotra and Dr. Jaideep Malhotra are experts. We are honored to have you, sir.
Thank you. Very good morning to all of you.
Sir, just to chair the session, I invite Dr. Prajwala Tiwari, madam. Is she there? Dr. Asha Jain, ma'am, to please chair sir's session. Dr. Anuradha Sharma, madam. Please, ma'am. And I also request Dr. Anjali Kanhare to please chair the session. Thank you, sir.
Very good morning to all of you. It's indeed a pleasure to be here in Bhopal in this wonderfully organized congress and for very, very effective and very academic workshops. So frankly telling you, I also wanted to speak on ethics and masses. But both of them have already spoken and so beautifully described the ethics and the aorta model. So I'll be concentrating on the uterus. Now, we know that menopause is a tricky situation and you need to have some screening guidelines for them so that you can pick up malignancies. And at the outset, it's still mentioned that ultrasound still remains the principal modality in assessing the pelvis in menopause and beyond, and even in adolescent, in reproductive. So it is ultrasound, and ultrasound. And the other CT, MRI and PET CTs are left for where the problem is not getting solved by ultrasound, which are very less. So what do? We do a trans-abdominal scan, we do a trans-vaginal scan, and where the vagina is very narrowed and cicatrized or they're painful, we do a transperineal scan, take the abdominal probe and put it on the perineum. So this is a transvaginal, this is a transperineal, the abdominal probe is used. So you can even study the urinary bladder even for the stress incontinence and all. Obviously, high frequency probe, we need to have color flow mapping, we have to have Doppler, we have to have power Doppler, which is very important because of the low velocity of flows and three-dimensional wear required. So power Doppler, saline infusion, positive contrast sonography, 3D, 4D, real time, this is all this is required. Now when we look at postmenopausal women, problem mainly is postmenopausal bleeding, which is the commonest problem which these women come to us with. About 5 to 10% of postmenopausal bleeding are due to endometrial cancers. So we have a goal of rapid exclusion of these malignancies with a minimal invasive method. So our aim of doing a scan is to improve the recognition of the pelvic anatomy, characterize what we are seeing, detect the tumor infiltration, and precisely depict the size and the volume as a guide to the surgeon. Now the common pathologies in menopause in uterus is atrophic endometrium. So that should be your common. So if the woman is bleeding and has a picture like this, thin endometrium atrophy, she's estrogen deficient bleeding. And if she has a very thick endometrium, either that's a polyp because it's localized, or a thick endometrium means hyperestrogenic. So that she needs progesterone, she needs estrogen. That is how, if the medical treatment has to be given, that's how we can plan your treatment. Then of course polyps, endometrial hyperplasia with or without atypia, and you saw a lovely slide of atypical endometrial hyperplasia with Dr. Gokhale's, where there are cystic areas there. And of course endometrial carcinomas. Then all the other problems like fibroids, pyometria, tamoxifen related changes, because some of them are on tamoxifen, all are there. Now For malignancy, the risk factors is she's over 60, she's obese, she's diabetic, she's hypertensive, there's unopposed estrogen, there is a use of tamoxifen, and she's had a Lynch syndrome or the family, what we call as a family history. So firstly, it has to be a clinical suspicion. The source of bleeding, by pulse speculum you can make out whether it's cervical. So a lot of the gynecologists have forgotten to do a pulse speculum examination and straight away the TBS. So that should not be forgotten. PS should be your first line. And then a PB examination, then the probe. So that's how we should be going. Then the HRT history, anticoagulants history, and of course a complete general examination should be there. Then the step 2 comes as the TVS. Now the TVS would be your first line of treatment if possible, otherwise we do transrectal or transperineal as I told you. Of course, a transabdominal overview has been done to look at the liver, gallbladder and the non-pelvic ascites or fluid collections and the lymph nodes and the other things. So an overview of with the full bladder of an abdominal, and then you do the TVS. And here we go to measure the uterus and the endometrium in the sagittal plane, assess the echogenicity and irregularity of the endometrium and look for focal lesions. So endometrial evaluation of palpable pelvic masses and screening of the endometrial and the ovarian cancers in high risk group. The complete evaluation is now vagina. So for vagina we can do a vaginal ultrasound by putting a jelly into the vagina and doing then the screen. So you can see the vaginal wall also. Otherwise when you put the probe in, it goes and you start seeing the cervix. But you fill the vagina with jelly, then introduce the probe, then you can look at the vaginal wall. So small vaginal polyps or vaginal lesions also can be seen. So we can examine the vagina by ultrasound. Then of course cervix, uterus, ovaries, extra ovarian masses, which you've been hearing, on the bladder, and a complete examination of the pleura, peritoneum, retroperitoneum, liver, kidneys, bladders. So you can't say I'm a gynecologist, I'm looking only at the pelvis, I'm not looking at these things. There could be a problem related to gynec which is coming here as a secondary or as a primary, including the breast. So now the cutoffs for measuring endometrium are many, and there is always going to be debate whether it's 3, 4 or 5. Now we say that a 3 mm cutoff after 5 years or more since menopause will greatly improve the specificity and false positive of endometrial pathology. So if you have more than 5 years post-menopause, then start thinking that there might be some problem. A 5 mm appropriate cutoff for women post 15 years of menopause and 6 for 5 to 15 years of menopause would be indicator of malignancies. So if you use a cutoff of 5, it is possible to reduce the number of invasive diagnostic procedures by 70%. So you don't need to do the endometrial pipple biopsy and you straight away go for treatments and other risks. So a threshold 3 to 5 and would be there. When we look at postmenopausal, the postmenopausal vaginal bleeding and not on tamoxifen, then the cutoff is 5 or less, and the risk of carcinoma is 7%. If it is more, then the risk of carcinoma increases. And for hormonal therapy, estrogen, then 5 million. If she has no history of bleeding, then the cutoffs could be higher because it could be a benign lesion. And if she's on tamoxifen, less than 5, 50% of those getting HRT or tamoxifen have reported a thickness of more than 8, which could be just benign. So if a woman is not experiencing bleeding and the endometrium is thickened, the guidelines are less clear. So there's a little bit of confusion in all these cutoff limits. So either you do a repeat TBS or you refer to the gynecologist, the oncologist. So how do we look at the endometrium? Now we look at the endometrium. If you see the sagittal plane, you see the line is very central. It is very less. It's an atrophic menopausal endometrium. If there is, and the glands on histopathology would be very less. If she has a little bit of estrogen or still menstruating in the mid-follicular phase, you will anteverted uterus, myometrium is all right, pouch of Douglas, the white line appears all right, the white line, and you see a 3-layer endometrium, which is does not look anything abnormal here. So, and it's in the cutoff limits. Now, if there is a thickened thing, then we can do a saline sonography. And even if you suspect there is some abnormality or even an atrophic, you can just put in a Foley's or even a feeding tube number 8 through the cervix and inject some saline, and you'll get an idea about it. So the atrophic endometrium is very thin, and there are no other problems. If the endometrium is thick, then if the endometrium is thick, then we measure and we include the complete endometrial thickness, not just one leaf, and the thickest anterior posterior is to be taken. If there is fluid, then you're measuring both the half on both sides and then adding them, not measuring the fluid. So you exclude the fluid inside and you're measuring that side and this side to get a total of how thick the endometrium is. Here also there is pyometria or hematometria. So exclude that and only measure the endometrial part. Now the other evidence which the studies shared that ET, endometrial thickness of less than 4 or 4 in a symptomatic postmenopausal bleeding, the risk of malignancy is very low. A simpler way to remember. So between 3 to 5, let's take it at 4. Endometrial thickness of more than 4 will require further evaluation by a pupil biopsy or a hysteroscopy or a saline sonography. And asymptomatic women with higher this thing, maybe 8 up to 8 may be accepted. If she is asymptomatic, then and there is no symptom, then you can give her progesterone withdrawal, and if it completely sheds off and becomes atrophic, it could be not just 1. If it is more than 11 and asymptomatic, then there is a 7 to 10% risk of cancers in postmenopausal women, and even in postmenopausal with bleeding, about 5. Or if it is atypical like that, there are cystic areas or very thick with cystic areas inside. So increased thickness, when patient is on drugs, we accept up to 5.5 with tibolone, we accept 4 with raloxifene, and we accept 8 with tamoxifen, and that's the 2020 guideline for thickness, increased thickness. Then you look at the morphology. So it could be simple or clear, or it could be collection, could be Asherman's, or could be masses which are indistinguishable inside and irregularity, and the myometrial endometrial junction may be disturbed. So if you have an abnormal morphology, then we can put in saline and look at the abnormal morphology by 2D or by 3D, and we can put on the color to know where the pedicle is. So when we put on the color, you can see whether the color is a chaotic secondary branching of the color, or if it's just a single pedicle supplied to that polyp, or the submucous fibroid, or what it is. So the international, like IOTA, there was a group of scientists who got together and formed what we call the International Endometrial Tumor Analysis, or IETA. Now IETA gave the evaluation of endometrium done during the peri and the postmenopausal. An important component is the quantitative analysis of the endometrium, that's a measurement. Thickness is best judged by obtaining a true mid-sagittal section of the uterus, either transvaginal or transrectal, and comprehensive achievement is done using color, power Doppler, 3D, and by using saline installation. So IETA terminology was to standardize the report which all of us give us, to improve the communication between sonologists and the clinicians, and form a basis of a validated risk scoring system. So that those were the IETA diagrams, and those were how they should be reported. Proliferative, secreting, and those standard figures and standard terminology should be used by all sonologists, all gynecologists who are doing the scan. The descriptive features, just like IOTA, simple and malignant, or MNS, endometrial thickness, symmetry, echogenicity, uniform or heterogeneous, endometrial myometrial junction, regular or interrupted, because if it is endometrial carcinoma, it's going, even if it is adenomyosis, the endometrial myometrial junction will be all broken there. And then look at the intracavity fluid or mass, and of course the vascular patterns, whether it's going inside or not. So that's how the IOTA. So IOTA features, you will measure the endometrium, you will talk about quantitative, that is echogenicity. So you can say 3 millimeter endometrium, hyperechoic, thick endometrial myometrial junction, not interrupted, and the junction zone and the color zone 1, 2, and the vascular pattern is normal. So that's how the report should come based on all these IATA features. Now this will combine the ultrasound. That's the other things: thickened, heterogeneous, irregular, interrupted, polypoid-like masses, lesions, or multiple chaotic vascular assessment. So we combine the morphology, combine the Doppler, and combine the clinical to get a complete report on the risk analysis. And that this will help to triage the patients which will go for biopsy, which will go for hysteroscopy, and which will go straight away for surgery or malignant treatment. So the simplified IATA scoring is endometrial thickness 10, endometrial irregular, no uniform, non-uniform echogenicity, disrupted, higher. This gives you suspicion of malignancy, and this patient's required a biopsy or hysteroscopy and further surgeries for it. Then we can, if their lesion is not being identified inside the cavity, we can put in some saline and see the lesion is bulging inside, and this is a submucous fibroid polyp, 0, because it is very less is going into the myometrium. It could be 50% in the myometrium, it could be more and just a bulge, but when you put saline and then when you put the power Doppler, you see it's got a single vessel supplied from there. So that pedunculated sessile lesion, outline the lesion and do the vascular. And when we did a 3D, you can very easily see the fibroid polyp which is there. So saline sonography, which is the simplest thing which you can do in your OPD, just after the scan, put in a feeding tube, just be ready, do the scan, inject saline slowly, and you see the saline goes inside and outlines the lesion for polyps of fibroid. So you can inject also gel, we do gel sonography also, and that's see how we are putting the saline and doing the vessel. Now if you have too much vasculature or less vasculature, when you do the saline, you will see that here's a fundal polyp which is hanging from there, and by 3D it is going to be identified much better, and then the color Doppler will identify. After this, of course, an office endometrial biopsy by Pipple, which is very simple and can be done for all various suspicions there, which gives you a high sensitivity for global endometrial pathology and lower sensitivity for focal lesions. So focal lesions, if you do a Pipple biopsy, you might miss the lesion. But if it is a full thickened endometrium all over, then this would work. Then of course the step 5 would come is your diagnostic hysteroscopy. So once you have a lesion where you want to further evaluate, then we go ahead and look at by the hysteroscope, so which allows a direct visualization of this lesion and a targeted biopsy. It is recommended when biopsy is inadequate when you've done a Pipple or the lesion has been focal. So your integrated diagnostic algorithm or overview will be postmenopausal bleeding, transvaginal ultrasound, measure it, do a morphology, IATA scoring. If it is less than 4, no risk factors, observe and reassure. If it is more suspicious morphology, do a biopsy and do a hysteroscopy. So very simple algorithm which all of us can follow. If it is recurrent or persistent postmenopausal bleeding, then we repeat the evaluation even if the endometrium is thin. And you can consider hysteroscopy even when the endometrial thickness is less, because there might be some very focal lesions which you are missing by this, and these are type 2 cancers which could be there. So postmenopausal, of course, causes have to be there. First is the local causes: trauma, vaginal atrophy, estrogen deficient, endometrial hyperplasia, simple, complex or atypical, endometrial carcinomas, endometrial polyps, cervical polyps, cancer cervix, uterine sarcomas, ovarian, vulval tumors, all that can come in. So it's complete evaluation need to be done, and based on all this, if it is atrophy, reassure, local estrogen if she has symptoms. If it is polyp, hysteroscopic polypectomy. If it is hyperplasia without aplasia, progesterone therapy and surgery, which I showed you. Thin endometrium, estrogen is your treatment. Thick endometrium, progesterone is your treatment. Atypical hyperplasia or cancers, then it needs a definitive surgical management. Now the special uses are when you are using tamoxifen. And here the tamoxifen uses, the endometrium may be thick, more than 8, and may have some cystic space. So only the ET may not be reliable, and you might need a biopsy also. You can stop the tamoxifen, give them a withdrawal, and see if it comes out or not. When it is very atypical and you're not very sure, then hysteroscopy to make a diagnosis, and of course these patients will land up into the removal. So the risk of endometrial cancer by this study was Dewellens et al. That if you have these features, these 10 scores, the score is scored at 8 or 10, then the risk of 9 variables, the value is 0 to 9, and the REC score is 4 or more, then malignancy. If it is score is 3, not including the GS saline, then again malignancy. So this has been published in the 2014, and you can still follow this simple scoring system to make the risk of endometrial cancer. So the flow chart would be for evaluating would be first a global evaluation, and if it is global problem of the endometrium, simple endometrial biopsy. And if you don't get a sample, then we switch over to the next step, which is the hysteroscopy. And if it is a focal lesion, then straight away diagnosis hysteroscopy or operative hysteroscopy. If it is an indeterminate lesion or there is a feeding vessel, then again we do a failed examination by Pipple, then you again go for a diagnostic hysteroscopy and then plan the further surgeries. So for all abnormal uterine bleeding, now it is known as heavy menstrual bleeding, AUB terminology or DUB terminology should not be used. The Palm-Cohen classification can be applied even in menopause. The PALM is PALM, polyp, adenomyosis, leiomyoma, malignancies, submucous and others, and Cohen, COIN is coagulopathies, ovarian dysfunction, endometrial dysfunction, iatrogenic and not yet classified. And once you do this Palm-Cohen, your treatment can be very, very easily planned and done. So for postmenopausal bleeding, a complete survey, 2D or 3D in color, diagnosing of the abnormal endometrial patterns, atypical patterns with dilemma, go for hysteroscopy. For focal lesion, rule out focal lesions, that is how you should proceed. Put on the color to see single feeding vessel or multiple feeding vessels. Display in 3D, if it is too many vessels, we can do the single or orthogonal view. Even if there are cervical polyps, you look at the feeding vessel where it is coming from. So cervical polyps per speculum. Look at the myometrium. It's not only the endometrium in the uterus, myometrium has to be evaluated. And for myometrium, the fibroids, the Musa scoring of the myometrium for adenomyosis. Adenomyosis could be focal cystic lesions, striae, all those, you can do the morphological uterine sonographic assessment or what we call as the Musa. So the key features of the myometrial are the direct signs where the endometrial tissue is gone into the myometrial cyst, hypogenic islands like this, and echogenic subendometrial lines. Indirect, the whole uterus is globular, asymmetrical, fan-shaped shadowing is there, like that, from the cystic lesion, and the vascularity and the junctional zone is disturbed. So this also needs to be evaluated by us. And diagnosis and scoring to be done on that. Key components of the myometrial is the corpus and the myometrium echogenicity and the junctional zone. These three to be evaluated when you're doing the myo. And accordingly, the myometrium pathology will be drawn, which could be fibroids of these 7 types, which will tell you whether surgery is required or not, or the lesions of endometrium, adenomyosis or fibroids, or any other pathology in the myometrium, or the vascularity, increased vascularity either by adenomyosis or by malignancy which has gone in. Finally, of course, the complete ovarian scan has to be done as told by the previous 2 speakers to evaluate the ovary by iota scoring. So the risk and benefits of when you say that can we apply ultrasound screening for all women just like pap smear? So yes and no. After 35, a woman to have a pap smear and a transvaginal ultrasound with color Doppler or a SIS every 2 years would be of potential benefit to pick up all the lesions. But it does not change the stage of the cancer by scoring. So our approach to all this would be TVS and then classified, because you have to classify the head and neck also. And this was a picture already shown to you by the aorta group, and then we have. Your examination is still not complete, and you have to evaluate the urinary system also when you are doing it in Menopause. So the dynamic assessment in sitting position, standing position, observation Valsova, pre and post surgical evaluation. You can see the angle, you can ask the patient to cough when you are doing the transvaginal. You see the bladder and the urethra, and the women have control at the external meatus, so the urine could be seen very easily. And when she coughs, the bladder will go back and the angle changes, and that you know that this patient probably has a weak bladder neck, and she will require either a laser or a PRP or a regenerative, or even if she goes to a urologist, it's surgery. If she comes to us, we will do all the regenerative treatment. And then you will also look at the bladder wall thickness for chronic UTIs, and you will look at the bladder wall vasculature also. That's how we evaluate. You see that the whole urethra is being seen by the TBS, and the angle is right, and when the angle, you see the bladder wall, there are some problem in the bladder wall, very thickened, so chronic cystitis and things like that. And then you can do the perineal wall also, so we can study the perineum also for perineal, old perineal body tears and things like that. So perineal evaluation also can be done by this. It still does not end, and with a woman in menopause, and you have to look at the breast also. So the breast sonography also, because you are giving her a complete risk analysis. So dense breast, palpable lesions, synchronous lesions, or intermittent cancers, and either palpable or looked by ultrasound. So the key take-home messages, ladies and gentlemen, is a USG scan for a uterus in menopause with transvaginal ultrasound is a cornerstone. 4 millimeter thickness we're going to take in PMP. Morphology will matter more or equally as much as thickness. Hysteroscopy for critical and focal lesions, and you scan the pelvis completely, scan the abdomen, scan the urinary system, and scan the breast. So ultrasound is going to be the mainstay for diagnosis in all the pelvic problems. It's indeed actually a boon to follow up also, saves you from many unnecessary surgical problems, and if you have 3D, 4D, of course you will get a bit. Thank you very much for inviting me here. I bring you greetings from Taj and from our new hospital. It's not new, it's 15 years now. Thank you very much for being here.
Thank you very much, sir, for the enlightening talk. And as always, you have even we were wondering whether we will learn about breast sonography, but sir had a few slides on that also. And of course, breast requires a complete session, but unfortunately we could not compile it in today's program. Thank you very much, sir.